Bournemouth University and Time to Change logos are shown on screen, followed by the text, Mental Health Triage, Dan Sadler, Team Lead and Mental Health Practitioner, Dorset Healthcare, Simon Thorneycroft, Mental Health Coordinator, Dorset Police. Then the text, this video is part of the Equality and Diversity outreach work being undertaken at BU. The video screen shows the logos Bournemouth University, Dorset Healthcare University NHS Foundation Trust, Dorset Mental Health Forum, the Richmond Fellowship, Liverpool.com and Dorset
thank you
Police.
very much.
The speakers are in a video on the left-hand side and the slides that they refer
Opportunity
to
for
on
us
the
to come
right,
here and
with the
present,
title
provide
Mental Health
awareness
Awareness
on
Week
what's been
2014.
happening nationally, but also locally within, again, a short period of time over recent months. There's no humour factored into this, so I think we'll want some crowd participation, but we'll see how it goes. The aspect of what we'd hope to convey today is a sort of national down to a local criminal justice liaison diversion down to street triage. So we'll come today to give you an awareness not just on the specifics of street triage, but that of where that service sits, and to some extent the background to our criminal justice mental health service as it's located within Dorset. So again, it's big down to small, criminal justice down to street triage, and we'll take this between us in terms of
Stan, the current speaker, gestures towards Simon.
And we'll finish them, but we'll see how we go. So,
slide changes with the title Dorset Criminal Justice Liaison and Diversion Service. Contents are read by the speaker.
Some background in terms of the Criminal Justice Service in Dorset. So in January of 2014, the service was chosen to become part of one of 10 national sites to participate in the evaluation of criminal justice liaison and diversion services within an NHS operating model. Again, in Dorset from 2012, October, there was a very, very small criminal justice mental health service working in the courts in Bournemouth and Weymouth, and working in the custody suites in Bournemouth and Weymouth. I don't know if people are familiar, but predominantly the majority of people retained in custody in Dorset are taken to Weymouth and to Bournemouth, and more locally people are processed far quicker in local police stations. So two big main settings. So there was a small service that became a big service in a very short period of time. So
slide is read by speaker.
What we'll put in there. So some background. I don't know if people are that familiar with Lord Bradley's report that was published in 2009, but it made specific recommendations for mental health services to be placed and work in close collaboration with criminal justice services within youth justice, within courts, within custodial settings. And Lord Bradley's report was widely disseminated and brought about some really influential recommendations.
Slide shows a diagram with the title The Liaison and Diversion Process in outline. The sign is a process with early intervention, criminal justice interventions, pre-arrest, arrest and or charge, court sentence, then the liaison and diversion, followed by the outputs such as mental health, learning disability, substance misuse, etc. Content is read by speaker and he refers to it while speaking.
That's a bit of a representation of what we are attempting to achieve. So you've got, I feel I'm hiding behind a computer here. You've got street triage sits in this area here, but the whole journey is captured in this diagram. This comes from the NHS operating model. It seeks to recognise at the earliest opportunity people presenting to the attention of the prosecuting authorities, whether it be in courts, whether it be the police, or whether it be services that work in close links with the police, paramedics, local authorities, staff. So you're more or less looking at the whole journey for the person from this early intervention, early detection in a street scenario, potentially leading to arrest, processing within a custodial setting, possibly ending up in court. And this is where our service sits in terms of providing close liaison and diversion where appropriate for people with recognised mental health and learning disability difficulties. We work on a process of case identification, secondary screening, because they've already been screened, that's why they've been case identified, and leading on certain occasions to an assessment of their presenting characteristics. Again, giving you some insight into the areas of work that's that's conducted.
Could I just, I'm sorry, I'm just going to try and put police context on this, so I do apologise if it kind of like cuts across. I was going to ask a loaded question of anybody been in custody recently? And I thought, maybe not, because that might go a little bit... So, the actual process of being detained and then taken into custody can be quite, well, it is traumatic, for a lot of people. And Stan and I kind of lived this for quite a while, and Stan's very... he doesn't pay enough service to his staff, basically. And by having his staff within the custody, and we'll go on to that in a little bit, it helps minimise that trauma, and it also helps minimise some of the issues that our staff face when dealing with someone like this. So there is this salving effect that takes place. And I do apologise, I'm not a medical student, so I'll probably use the wrong words, and then afterwards you can tweet and go, did you hear what he said? It doesn't really matter. What I'm trying to say is we really value this service, and it sometimes delivers the hidden unquantifiable piece that really makes the journey a lot easier for the service user. And this is what this is all about. Sorry, Stan.
No, that's grand. Thank you. Thanks for the humour as well.
No, it was not intended.
Yeah.
Slide changes then is read by speaker.
Okay. In terms of what Lord Bradley identified, this is trying to get a consistent approach throughout the whole country. It's not just what we do in Dorset, what's done in Hampshire, it's what's done through England in terms of our approach to early recognition of health difficulties. Lord Bradley talks about an assessment, a liaison and a diversion. Because liaison and diversion means different things to different people, but in terms of our world it means specific things. So the assessment at the earliest opportunity seeks to identify and assess people as early as possible, possibly entering the criminal justice system, but as our service has evolved, it's before they've even been arrested. This application of 136 doesn't come into the context of an arrestable offence. So the work that we really do is participate in assessment and thereafter conduct a liaison process to provide support to the person, provide advice to the person, and to provide support and advice to the partnerships that we work with, whether it's a police officer, a paramedic, anything. It could be any concerned relative, a friend, a magistrate. And where appropriate, we endeavour to support effective diversion out of the whole criminal justice interface of individuals with identified vulnerabilities.
Slide changes with the title, the key aims of the Liaison and Diversion Service are...
Again, to reiterate,
Content is read by speaker.
the key aims of the overarching service, not just street triage, is to improve access to healthcare and support services for vulnerable individuals through effective liaison with appropriate services, ultimately leading to a reduction in health inequalities. And that's really the big drive in all of this. A big part of this process is the evaluation. It's the statistical measuring of every single contact we make, and we're part of a national evaluated pilot. So we do 90 data set items for every single person that we screen and assess, and so we've got quite a lot of statistics. And what we've recognised through the 2 years of operating is that 30% of the people we see, that's their first involvement and engagement with mental health services. So that's providing access to people who might not have had a mental health appraisal or a learning disability appraisal. So that's really quite significant. More recently, we've become part of the youth. It's an all-age service. Up until April of this year, we only focused in on adults. But we still, where youths were brought into custody, we conducted assessments. But now the whole service, out of custody, in custody, is that of an all-age service. Getting to a situation where we can promote as much as possible efficiencies in youth and criminal justice systems. And what that really means is that where people that don't need to be prosecuted, that don't need to interface with police and courts, then that doesn't happen. Therefore, there's time saved in policing, there's time saved in courts, there's time saved in youth offending services. You don't need to consult on individuals that we've appraised. So it leads to less strain on courts and youth justice panels. And fundamentally reaching a point that our efforts lead to better health and social functioning and possibly reduced offending. So some people are unwell when they offend. So if we can identify them at the earliest stage, divert them into health and social care related intervention, then their health and social care outcomes are far, far better at an earlier stage, leading to hopefully better functioning.
And there is probably another one on there actually, so Stan's going to kick me if I think it'll come in. You know, it's around the prevention of criminalisation. So if you read some of the reports, certainly HMIC's, the Magistrates' Inspection of Constabulary, criminal use of police cells, there's some quite powerful quotes in there, you know, and I will paraphrase one. I was ill, why did I end up in a police cell? And it is, you know, we're not here to criminalise people, and by these schemes, we go in some way to mitigating that as well. So it is kind of like to reduce reoffending, but also kind of try and minimise the criminality aspect of it as well.
People are arrested, they're brought into custody, there's an intervention provided, and on occasions the police make a decision not to prosecute.
Yeah.
Whereas without information there may have been a decision to process, to apply bail, to expect attendance at a magistrate court in a month's time. So there's real benefits to appropriate application of due process.
Yes, certainly. That's it's a joint report. It's a Magistrates' Inspector of Constabulary, and it's a criminal use of police cells. I think it came out in 2012 or 13. I think it was with the Care Commission as well. I think that's they had a hand in it. Thank you.
We've got our contact details on the end of the slide, so if there's, we'll do questions at the end, but if there's further mailings, please contact Simon.
Slide changes with the title Service Expansion. Content is read by speaker.
So again, to set some context, what we're trying here again is to get eventually to street triage, but give you the backdrop to where that service sits, to give you some context to the world that we've been living through over the past sort of 2 years, and more significantly in the past 6 months. So up until March of this year, there was only 3 practitioners. So it was me and 2 others, and with the back of the room some support in terms of part-time administrator. So following the success of our application to become one of only 10 national sites, we got, proportionate to our original budget, far more money. That allowed us to think creatively with a budget, not spend it on big expensive things, but spend it in a way that we thought was really responsible. So we came up with a model, and I'll show you that in a minute. So we had to deploy and employ an extra 19 staff over 6 months. And that was very, very challenging. All the issues of recruitment through advert, the pilot funded service, so who's going to support pilot funding other than short-term secondments and fixed-term contracts, and who's going to work in a service like that. But we got a real, I think,
buy-in.
Yeah, a lot of support from Dorset Healthcare, from our director, who made all posts substantive, permanent, taking a risk. But that really did pay dividend in terms of allowing us to go to advert on permanent contracts. So we sequenced that from March through April. We repeated until we were able to reach our full cohort of staff. And what we've now got is a breakdown of 12 qualified mental health practitioners. And those practitioners are either trained as social workers, they're trained as mental health nurses, or they're trained as nurses in learning disabilities. We have 1 occupational therapist. We have 5 support time recovery workers. And we have some far better administrative support than we ever had before, because that's really important in terms of measuring the service being part of an evaluated pilot. So we have policy implementation lead. She's come here today to witness what's going on. We have extra administrative support, and we've also deployed an information analyst, because that part is really, really important in terms of capturing all the data from the control room, from the field workers in the street, from the workers in court and those in custody settings. But all of that hasn't been easy, and each member of staff has been subject to advanced police vetting. That's been an experience in itself, to work closely with prosecuting authorities, police and courts. It's not just the DBS. There's advanced vetting, and you can fail in terms of your credit history. So that again influences the recruitment of new members of staff. So once we get them in, we've got to induct them, expose them to new settings. It's a different world completely from a acute care setting, a community mental health team, and that takes shadowing and close links with the staff. We'll move on, but there's other issues affecting it as well, in terms of access to wireless networks and ensuring all of our hardware operated in another setting, in police settings, court settings. But we got there, or we're getting there.
We're getting there. And the reason we've gone Stan's put the advanced police vetting, he'll come on to it later on, is because of our operating model. We just don't like vetting for the sake of vetting. We are very open in how we share our information with our colleagues from Stan's team, because the more you put in, the better you're going to get out. So it's making sure that they've got the full range to the information that we hold is appropriate for what they're using it for, enable us to get a better informed decision back, and we'll show you some case studies later on.
Because you've actually got a scenario now that the street triage workers are witnessing through access to the police database the incidents.
Yeah, that's right.
The police incidents, so that an early interpretation, an early intervention can take place. So that's the reason for the advanced vetting. And that have also PNC checks on the day. Sorry.
Police National Computer.
In terms of historical offending risk, to help inform our risk assessment and management. So that gives you some overview of what I've just said.
Slide changes with the title Dorset Criminal Justice Liaison and Diversion Service. Has a diagram showing the staff numbers in different areas. Underneath the team lead you have 3 support staff, 5 Bournemouth custody staff, 2 in Bournemouth Court, 3 Youth Justice, 5 Weymouth Court and Custody, and 2 Street Triage.
Again, the bit that we'll eventually come on to will be the 2 mental health street triage practitioners. But that's a staffing of 23. 2 of those are practitioners who will work in the street triage. And what we've got is a rotational situation, that you may work in custody for a period of time, and then you may move out and do a month of street triage and move back.
Slide changes and is read by speaker.
Hours of operation. So this Criminal Justice Liaison Diversion Service now operates some days of the week 24 hours, but we start at 7 on a Monday AM in police custody, and that worker finishes at 8:30 PM on a Monday. So Monday, Tuesday, Wednesday, Thursday, that's the operations. On a Friday morning right through till a Monday evening, there's 24-hour cover, because that's where the street triage and the criminal justice practitioners in custody work hand in hand.
Slide changes with the title Governance, with the Criminal Justice Liaison and Diversion Service reporting to the board. The board then report to the Head of Health and Justice Commissioning NHS England and Health and Justice Commissioners NHS England.
A little bit of the governance. Every aspect of what we do is subject to project board scrutiny and coordination. Every aspect of what we do is part of a national operating model, and the street triage is a local initiative, is evaluated by partner organisations. We've got very good relationships with all the partner organisations, from the respective local authorities to NHS England to the CCGs to Dorset Police.
Slide changes and shows a graph with the title Case Identified. It then has the number of cases identified per month. The speaker reads the information.
Right. Quick look through some statistics before we go on to the nitty-gritty of what street triage actually is. So, in terms of street triage right now is an evening, night thing. This is the daytime operations in terms of people presenting to custody and court. It's not street triage statistics. But from April There's been a far higher recognition of cases that this service has intervened in. And that's been hand in hand with the mobilisation of staff. So, like here we've only 3. Right in October we've got 12 practitioners and 5 support time recovery workers. So 17 people out and about. You'd expect the statistics to be far higher, and they will increase and increase because far more cases will be identified. So of that number were screened only. So they didn't result in a face-to-face assessment.
Slide shows a graph with the title People Assessed. Speaker refers to the data.
Of the remainder, that group had a screen and a face-to-face assessment. So, in the month of July, 104 people were seen face-to-face in custody or court settings by the practitioners. That number's again continuing to increase and be supported by those that are seen in the street triage period.
Slide shows a graph with the title People Assessed Bournemouth and Weymouth. Speaker explains the data.
Simple breakdown of locality. Bournemouth, Poole, takes in a very urban, densely populated area. Weymouth, far more outlying, rural in its sort of composition. So it tends to be each month a 70 to 30% in terms of presentations to court custody and also to that street triage. So, in the simplest term, just an overview.
Slide changes with the title Intervention to Address Mental Health Needs, with results such as referral made to another agency, admitted to hospital directly, advice give other. Speaker refers to the data.
Of those that we screened and assessed, where there was recognition of a mental health issue, it gives you some insight into what the service was endeavouring to address. A lot of the people we're seeing are currently or have been involved in mental health services. A small proportion are or have had involvement with learning disabilities. A big part of our role is to reappraise current presentations, to reappraise previous presentations, and to make appropriate referral on, where indicated, to the relevant mental health, learning disabilities, social care settings, or where necessary to help to inform on the requirement for a mental health act assessment in custody or court setting.
So just as soon as you come into custody, the custody sergeant will have a risk assessment based, and part of that will be a health risk assessment. So bearing in mind what some of the responses to that will trigger then actually to stand staff to come forward and then deal with that individual. Also, in the Police and Criminal Evidence Act, it's quite specific. If a custody sergeant has any concerns about physical or just it says the well-being of a detainee, they should be seeking medical advice. So this is quite a complex and yet very compact in time process that will take place at support stands.
And I don't like this one.
Speaker points to the board.
With little choice, this is taken from our national statistics that we supply on a monthly basis to NHS England. What that really boils down to is that they've been assessed, their needs are already being met by an existing team, but they've had a reappraisal, they've had support, their whole journey through custody or court has been supported by the engagement and work of the support time recovery worker or that of the practitioner. So that's some insight into it.
Slide changes and shows a graph with the title Main Offences When Charged.
Being done.
Speaker refers to the important data.
We've added this one to give again some flavour to the type of offence that the population we're dealing with are being charged with. They're not being convicted with it, they're being charged and it's gone then to court. So violence against the person, and that's not unique to Dorset, that's a national representation. High number of offending results in a victim. Violence against the person. Another one is criminal damage. We tend to see that a lot in mental health and learning disabilities. People who are not acting out, but they're very much emotional, caught up in a crisis, and their expression can often be resulting in damage to what's around them. A few others, I think there's only really one murder that we had to deal with.
Yeah.
But a few other interesting ones in terms of possession of knife, a few of firearms, but it tends to be more acquisitive crime in terms of theft and also the violence.
Slide shows a colourful graph with the title Needs Identified on Complicated Assessments.
Slide for colour.
These are rated by month and assessment. Speaker refers to the data.
I quite like this one because it does really display a real recognition of the needs that we identify when assessing people. Really, really high of mental health, really high of alcohol. This is significant. And that's probably an under-recognition. There's a lot more people than we think that are processed through police and courts with a learning disability and difficulty, and it tends to be the realm of difficulty, not quite meeting the threshold for a diagnosed disability. They have communication issues. You might these things tells a bit of a story. But, we often see it in custody that people with learning difficulties, communication problems, often say very little and don't have their true vulnerabilities recognised. They just want through it as quickly as possible. What we've done in this service, and there's some information at the back that will help to support that, there's web links. We've actually recruited 6 practitioners who have a qualification in learning disabilities, and that's of real significance in terms of educating our own staffing, educating partner organisations, and also being there to recognise the needs of people with communication difficulties, learning difficulties, ability to process the nature of why they're being investigated or why they've been engaged with the police in a community situation, or those that have a recognised learning disability. So that's a lot of good work that we've done. A little bit on youth.
Slide shows a graph with youth activity from July to September 2014, showing the number of referrals, screened, assessed, referrals made, needs met by another and advice given. This is discussed by the speaker.
Youth is new for Dorset's L&D service, and we really only went live in terms of our service in June, and we've had to change it a little bit. Adapt to the local landscape, because in Dorset there is a very good youth offending setup, youth offending service in combination with the associated yachts. There really wasn't much of a role for us to work in an area that they were operating in, so what we had to do was consider an alternative, and that over recent weeks has resulted in again significant development, allowing the youth workers, and we've allocated 2 practitioners and 1 recovery worker to work very, very closely with the safeguarding referral unit in Dorset Police. So recognising, before even consideration of a criminal matter, vulnerable youths within the community, where there's recognition of their vulnerabilities, and it's come to the attention of the safeguarding units.
The safeguarding unit is if you like, is the focal point for all the concerns that police officers may have around vulnerable adults, vulnerable children, missing from homes as well. So it doesn't necessarily mean it's criminal activity, in as much as that now we're able, because of the STANS team being embedded into that unit, we're able now to get another level of information, another assessment on that individual, and to assist us as well.
And it has resulted in activity, and it's a county-wide service, so it could be in Lyme Regis, it could be in Bournemouth. It's just the nature of a 1,000 square mile county and population of 750,000. So 2 workers are having their work cut out to do that, but we're doing what we can do during an evaluative pilot.
Slide changes with the title National Content to Street Triage. The speaker reads the slide.
I think why most of you are here today is to gain insight into that of street triage. So nationally, financial investment and support for the concept of street triage has made it possible in many areas of the country to implement new schemes. Some have received direct funding from the Department of Health to participate in an evaluative pilot. with some other areas. That's us. We're funding them directly through partnership agreements. As a consequence, approaches throughout the country reveal differences in operational design and application. So, because so many people are doing it differently, that could have influenced a situation likely to lead to a wide variation in outcome and experience. And what I mean by that is, some may work certain hours, some may work all the hours, some may have 20 staff, some may only have 2, some may deal with an urban population, some may deal with a rural population. Some may work in the back of an ambulance, some may respond to incidents. Wide variation, some may be run by local authorities, some may be run by health. Wide variation.
Slide change with the title Crisis Care Concordat. Content read by speaker.
A very important document, the Crisis Care Concordat. So it was launched in February by the Department of Health. It's a joint agreement which describes how the police, mental health services, social work services and ambulance professionals will work together to help people go through a mental health crisis. And what we mean by a mental health crisis, it could be somebody with communication difficulties on the back of learning difficulties, learning disabilities. It's just their experience as represented in their mental health at that point in time. So the Concordat endeavours in supporting coordinated action across multiple agencies to constructively and collaboratively improve intervention and outcome. And I think that's what we've got here in Dorset, because the local implementation group is fully representative of the clinical commissioning group, the 3 respective local authorities, health, Dorset Health Care, and that of Dorset Police. And we also, through our participation in the multi-agency Section 136 group, have that of South West Ambulance Services.
Slide changes the title Dorset Mental Health Street Triage. Content read by speaker.
So our local context. So a local task and finish group met in January this year, which included representation from health, from local authorities and from police. It was tasked with the initiation of Dorset's mental health street triage and had been supported in large parts by the Police and Crime Commissioner Martin Underhill. Martin's role is, in a lot of ways, is to chair mental health nationally from a PCC point of view, and Dorset was not successful in being part of the national pilot, so there was a real risk that Dorset would lose out. I think it was really significant in terms of Martin's support to get something off the ground locally. So we met in January, and in June the service became operational, so not a lot of time. So the background is that Dorset Healthcare was invited to provide the triage service. And that decision, I think, in large parts was down to the fact that we had an already embedded liaison and diversion service in custody in court. We had staff who had already developed relationships with Dorset Police. We had relationships with the 3 respective local authorities. We had an IT infrastructure that was available in those settings. And also we were going through a period of active recruitment of new members of staff, so we were able to advertise at the same time, and through our ability to succession planning, whatever you want to call it, we had an ability to cover during periods of absence through our cohort of staff working in court and custody during day hours. So we commenced a pilot service on the 27th of June on 3 nights a week, between the hours of 7 p.m. and 8:30 a.m. Again, everything subject to change, subject to influence. It's the first stake in the ground, really. This is what we're going to do. We're going to evaluate it. We may have to adjust it.
Slide changes with title National Examples. Content read by speaker.
A little bit of insight into some other schemes. There's many. But in West Midlands, West Midlands Police operate in combination with Birmingham Solihull Mental Health Trust and West Midlands Ambulance Service. They've actually got a situation, what do they call it?
A grey van, is it?
Grey van, I think. It's a scenario where police, health and the paramedics respond to an incident. So they're able to triage a potentially vulnerable service user at the street level, identifying characteristics which may require appropriate treatment at emergency departments, or they may deal with it locally because they've got a paramedic on hand. But there's gain in that, but there's also some limitations. In Lincolnshire, just another example, a paramedic and a nurse share a triage car without an accompanying police officer. This arrangement of combining a mental health nurse and a paramedic would suggest an ability to respond to an incident instead of or as well as a police officer. So it gives them that opportunity. That's only two examples. There are a few.
Slight changes with title, national examples, important content read by speaker.
So, local context, Dorset. It's a big county, it's a mix of densely populated, high morbidity, difficulties in and around the urban areas of Bournemouth, of Poole, of Weymouth and Portland. But thereafter it's quite an outlying area of a mix of market towns and smaller villages. So it's very, very difficult to provide a service that's a best fit. So Dorset has a population, as I mentioned earlier, 750,000, 1,000 square miles. It takes you a long time to get from Christchurch to Lyme Regis. And it's complicated by tourism and tractors. I don't know, think that up. It does take you some time. So, Dorset Police, together with partner organisations, explored the various national operating models. And due to those factors, it was considered not justifiable to have a grey bus or a triage car, because you couldn't respond to every incident. But part of me also thinks there's a big exchange of information through partnership working, and what that ran the risk of is becoming a situation where you had an expert from police because they did all their work with a mental health practitioner. We want to share that around. So as a consequence of, I think it's a very pragmatic approach, appreciating the size of the county, difficulties. So our current approach allows for a mental health practitioner based in the control room in Winfrith, having the ability to share the information with the police controllers to assist frontline officers in policing incidents. And additional colleagues available to respond to community incidents by their location being predominantly in Bournemouth custody. That's, from our examination, a lot of the call-outs are in this urban area. Maybe Simon can lend some context to the Force Incident Command Centre, because a lot of people make decisions in that area. You have access to a Chief Inspector of Custody who helps with some of the decisions.
So basically, every time you phone the police and it comes to Dorset Police, it comes to one point, which is the Force Incident Control Room, which is at Winfrith. So you've got usual radio operators, telephone operators, and then we have one individual who's basically in charge of the force operationally, the Force Incident Commander. Bolted onto the back of that is what we call a risk management unit, and I'd like to say it's all sexy and it's an intelligence cell and all that malarkey, but it's some people that sit there and do some research on incidents and basic databases. What we found out, without stealing too much of Dan's thunder in a little bit, is by having the health practitioner there at that point, they get the overview of the force, everything that's going on, all comes to that one point. So as the point stand made before, where you could have had one healthcare professional driving around in a car with one individual, and they'll talk to each other and there's a little bit exchange of information and exchange of experience. By putting that individual in the force control room, in effect they're influencing all the operational officers that are out at that time, because they can access their incidents, they can access their information and send that advice out. So we're getting a greater spread of awareness of what the team can do, and of what we can do as well that's operationally correct for the individual in front of us and the circumstances everybody finds themselves in. Thanks, Dan.
Yeah, thank you. Just early recognition of vulnerability through access to already existing systems. And we've got good systems for access for information.
Slide changes. Content read by speaker.
So the purpose of street triage. Many people have an understanding of what it's actually endeavouring to achieve, but it's a first response team or person. It's a first response which, at the request of the police, will attend situations involving mental health issues and triage people of all ages, whether they have learning disabilities, learning difficulties, personality disorders, substance misuse, or mental health issues. The response will be at the first point of contact with the police at the operational level and prior to a decision to detain a person under the Mental Health Act. That's what we work through in terms of our process flow, some of the work that's been done nationally, some information up at the back that helps the service and the police to make an appropriate decision. Because if there is a suspicion of a crime being committed and that requires further evaluation, there's maybe a justification to bring that person to custody. It may not result in a prosecution because there'll be practitioners there to help. But when there's no suspicion of a offence, and there's evidence of a significant vulnerability that would affect that person's safety or those around them, then Section 136 has to be a consideration that then allows a police officer to detain that person, take them to a place of safety. The objectives.
Slide changes. Content read by speaker.
So divert people from criminal justice services when appropriate. So what we do at night is what we've been trying to do during the day. We provide access to community-based services, thereby ensuring that the health and social care needs are known and provided for by the appropriate services. The part of our partnership group from the CCG, Elaine Hurrell, is always supporting the requirement to ensure that there's appropriate referral on to services in health and social care. How do we evidence it? And it's really important that the work has to be done in terms of measuring the referrals that arise from that engagement to ensure that a GP gets to know where appropriate, or a referral goes on to an associated mental health team or to a local authority. And that's part of the work that goes on with the street triage services.
Slide changes. Content read by speaker.
A little bit more on what we've already said. The implementation plan, we started on 27th of June. We did about 5 weeks as phase 1. It was predominantly Bournemouth, 2 workers working in Bournemouth. We had this great idea that we could work after 4 weeks in Weymouth. And that was to help the new members of the staff adapt to night working. Not everybody's naturally good at night working. It can be quite a long shift pattern. But what we are finding is that there was probably not enough awareness of the service through awareness in local authorities, through approved mental health practitioners, through acute care, through policing. And the service really wasn't that widely known and widely used. That's why we changed the emphasis. So after about 5 weeks, from 17th of August, we located 1 practitioner in the command centre at Winfrith. And that has made some significant differences in terms of responses. And as a consequence of that, we've come on to phase 3, which is to continue phase 1, but more or less make that a permanent arrangement to appreciate the size of the county and the need to be at the centre of all the decisions that are made. And that worker practitioner is supported by another mental health nurse or a social worker, or a nurse trained in learning disabilities, responding to the community incidents when they arise from their location in the custody suite. And they're also there in custody to support the police staff during nighttime operations if there is a vulnerable detainee. And also there, if the computer breaks down, we've got a
Absolutely.
backup plan, which can happen as well.
We do have a robust IT system now.
Yeah.
Can you just mention about phase one, the implementation and the awareness bit? So we just didn't sneak these people into custody in the control room in the dead of night. We did this big fanfare launch, all our staff, all your BBC got in touch, everybody, and it's like, so, that's why we're here, because no matter how well you think you're doing with the awareness, you've still got to carry on with it, and, this is part of my role, is this continual push of awareness within the police and without the police, so just when you think you've got it right, you just give it a little push. So,
I think partly coming here today helps a lot with that as well.
Yeah, absolutely.
Slide changes. Content read by speaker.
A little bit on the activity. So when we start 27th of June, we've dealt with, for the first 10-week period, we're now into about week 13. But because our information analyst has gone off on holiday, I've only got week 10, up to week 10, so everything breaks down when he leaves. But it's a useful insight. So 112 incidents over 10 weeks. 112 were screened, leading to 19 face-to-face assessments. 59 male, 53 female. Age range, quite interesting, 12 to 93.
Slide changes. Content read by speaker.
20% of the incidents were involving people under the age of 18. And this week's statistics highlights a high number, at least 20%, 16, 15-year-olds.
Slide changes and shows a graph with the title Nightly Incidents, with 25% on Friday, 32% on Saturday and 43% on Sunday.
Nights of the week. So you start at 7:30 p.m. So at 7 p.m. and work through to 8:30 a.m. Friday into Saturday. Finishing on a Monday morning. This did surprise me. I thought Saturday night might have been the one, but it's a Sunday as things stand. I don't know why.
No, we're filming this, so I won't mention why. I think it could be. So.
Alcohol plays a big part. I don't know. Other than that, people, I don't know. Monday morning's not a good day.
Yeah, it could be by Sunday everybody's had enough of the weekend. You kind of know what I mean. So it just drips over a little bit.
The higher prevalence, almost double that of a Friday into a Saturday morning.
Slide changes shows a graph with the title Time Incident Recorded. 12% being recorded between 7 and 8, 46% between 8 and midnight, 28% between 1 and 4 a.m, 14% between 4 a.m and 8 a.m.
Again, of significance, the timings of the incidents when recorded. These ones tend to be some work that's awaiting the intervention of the practitioner's arrival at 7 p.m. But really, 8 o'clock through till midnight, almost half the activity. That's useful because it helps us to tailor the shape of the service and when people work. Again, it's a very, very short period, 27th of June.
Slide changes shows a graph with the title Weekly Breakdown, with the number of street triages screened and assessed by a week. Important data read by speaker.
Some insight into what went on from the start, a bit of screening, on to assessments, more assessments, the move to Winfrith, and then the screenings and levels of activity pick up. And 2 weeks ago, I think we were almost 60 screens. Last week we had closer to 50. Last week just gone, it's around the mid-20s, but we've had a lot of IT issues that interfere with that.
I understand. Are the assessments taking place in custody?
No, those assessments are taking place in the communities. It's not a huge number of assessments, less than 20% in some of the earlier work. They're taking place in the community, face to face. A couple have taken place at the reception outside the police station. People have come seeking assistance, and the staff have been around. That's quite an important role that the police station reception can play. Point of safety for some people. But some have taken place in the community, and one in particular was a really, really challenging situation that raised a lot of safeguarding issues, not just for the person being assessed, but a family member, and also the staff who were challenged by a lot of animosity and aggression, and I think a pet or two. So it can be difficult.
Slight changes. There's a graph with the title Mental Health Needs Identified. Personality disorder 11%, attention deficit disorder 6%, anxiety, phobia or panic 29%, depression, bipolar, schizophrenia all 14%, organic disorder 3%, adjustment disorder 9%.
So the mental health needs that are being identified,
Speaker points to personality disorder.
I thought would be in here somewhere. I thought that would have been, I thought would a lot of people challenging, but it's not. It's people that are in a crisis. They're highly anxious, they're distraught. It's traumatic for them. Depression, bipolar, schizophrenia, far more prevalent than that of some personality states. This plays its part. It's self-explanatory in a lot of ways. People adjusting to difficulty get into a crisis, and then difficulties ensue. Again, short extract, 27th of June. Just to add to that,
Graph shown on screen with the title Other Needs Identified. Alcohol misuse 40%, substance misuse 7%, social and communication 2%, suicide self-harm 40%, accommodation 9%, financial 2%.
alcohol plays a big part in things. Substance misuse to a lesser extent. Accommodation, something of a problem. But overwhelmingly it's a bit about how the person manages themselves and become emotionally challenged and contemplate injuring themselves or neglecting themselves, putting themselves in danger, walking onto a road.
How many do you think are a mixture of those?
I don't
I'd
know,
imagine
but
a lot of
a lot of
cases
them.
are.
Yeah, a lot of them.
There could be some double counting, but
Yeah.
Graph shown on screen with the title Intervention
There
Outcome.
will be for sure. That really helps to paint a picture of some of the factors that do influence mental health functioning.
Speaker reads important parts.
This is a good one for us in terms of examination of what has been done thereafter. So what has our intervention actually led to? That over half the people we deal with, it's resolved through them residing back at their home address. I don't necessarily use it as a place of safety, but it's being resolved through the engagement and that person has gone back home. A few others, some have to end up in custody.
yeah, so
Some end up at accident and emergency departments. Some end up in more specialist areas, like your Linden units or rehabilitation unit in the west of the county. Some are signposted to crisis home treatment in an acute situation, so the local crisis team respond either by way of accepting a new case or getting involved in an existing presentation. Just some insight there.
Slight change of the title Case Study. Information is read by the
It's
speaker.
a case study.
okay. First of all, I've got to apologise. I'm not as IT savvy as Stan, so the slides might go backwards. We'll go with it as best as we can. If I can ask you just to cast your mind back a few slides to the crisis Concordat and the Lord Bradley report. This kind of gets it all in the one, I think. And we didn't go particularly fishing for this one, but I think it's a really good example of joint multi-agency working, appropriate use of use of powers if they're needed, and making sure that we're bearing in mind the needs of the individual. So this is a Friday night, and it was in the summer actually. So bearing in mind the summer we've just had, this was a really, really busy period. And you can read it yourself basically. I just want to kind of like speak to it a little bit. This is quite a common occurrence. We'll just get a call from a hotel saying we're concerned about member staff. Sorry, concerned about a resident, one of our guests, and then this talks through. So, the police and the mental health triage worker who are in the control room. If you just cast your mind back a little bit to the risk management unit, they're pulling information through about this individual that are on our databases. Stan's team then are able to pull information through about the individual from their databases, and this is what they found out between them. Frequently attended A&E, already spoken to crisis team, had a diagnosis, and a recent MDT had determined he was not deemed to be immediate, and that's the key thing for us on the section 136, significant risk of harm to self, and could be encouraged to utilise support. So then, using Stan's team, and this is where I'll touch on it in a slide in a moment, Stan's team have got the intimate knowledge of the organisation around the health. So rather than me picking up a Dorset Health or Dorset NHS phone book and trying to figure out who lives where, Stan's team straight away into the crisis team, and they made that contact. And there we go, it was driven on by the crisis team. And that's the quote from on the night. That was an individual.
Did you say what MDT is?
Simon asked that question on Thursday. That's a multidisciplinary team. So this man, he was involved with a local mental health team.
Sorry, the other question very quickly. What would you class as recent?
It was the day of the attendance.
Yep.
Yeah, that's one that we've really got to visit regularly. Immediate is on the day within that context of that situation. He was under the care of mental health team. He was under the care of the crisis team. There was a relapsing episode of there was some degree of affective instability. So I'm not quite sure of diagnosis. What we got, paranoid schizophrenia, and the difficulties affecting his learning and process. And he'd been at A&E and he never got what he felt was right, and he walked across the road to a local hotel. So they must get it all the time at that one. So
you can figure out where it is, can't you?
Yeah, and it was a highly charged situation where there was apparent vulnerability, and the reception staff phoned the police. The police intervened, and it could have escalated without that swift intervention through the police engaging with the service, and with that service in Dorset Healthcare engaging with the partners in the crisis team, who agreed to meet him and then convey him, take him home, because he was under their care. But yeah, a really good opportunity.
And again, there was a little bit about managing the expectation of the hotel staff, because they phoned up the police, they expected to see the police arrive. But we were able to manage this without police officers attending, and in a way that probably de-escalated the crisis a little bit as well for the individual.
Slight changes with the type of considerations. Points are read by speaker.
I kind of got the demographics wrong for the next couple of slides, so this is down to me, I do apologise. But anyway, imagine yourself, you could go do this. So these are some considerations that our joint work has now got a face looking forward. And it is that nationally there's a drive to make sure that we might be funded centrally, but we're going to make out our best fit locally. So this is where the best place for the decisions to be made. The nearest the point of contact is for that to happen. As Stan's pointed out, Dorset is quite a challenging county for those issues, and so the one size fits all doesn't work for us. The West Midlands model wouldn't work for us, the Lincolnshire model wouldn't work for us, and I would suggest you could pick a lot of other models, because of our challenges it won't work. Since it's gone live on the 27th of June, there has been a couple of iterations, but the sense is now that this is probably the best fit for Dorset in an operating model. There might be some more work about support work and things like that, but the actual application of what the street triage team is there for, this is probably the best fit. And again, it was some of the triage would appear response to high levels of 136, and it was more about the 136 ending up in police custody,
Yep.
as opposed to the 136 ending up at a medical place of safety, i.e. St Anne's. So we are working quite hard to drive down on the number of 136s that actually come into custody, and that's quite an ongoing piece of work. But again, it's as you can see from that case study and from the example before, we're reaching people that we may not have reached in a supportive manner before through the street triage, and it's fair to say quite a few of them may have ended up in police custody, and then we start with the criminalisation issue, which is what we're trying to do. And then the other thing as well is the funding variation across the country. That will affect the operating model design. No doubt you can see it, different people getting different levels of funding from different sources.
Slide read by speaker.
So these are considerations that, and this is 3 questions that back in January I think we went through. What does street triage mean to you? So some people, street triage made a paramedic on a motorcycle zapping everywhere. To some people it may have been a minibus full of health professionals. And, you kind of turn up, it's what it is to you. And I think once we've got the common agreement across our partners, then we were able to proceed as well. And very quickly as well. And what are you seeking to achieve? Drive down 136s? Criminal use? That kind of thing as well. And do the partner agencies have different objectives? We're very fortunate in Dorset, and Stan's touched on it a few times now, is that there's been a real strong can-do attitude about this. And if you can see from January to June, and then the further expansion of the scheme and that is just amazing. That's been achieved through a background of everybody having the same objectives.
Slide changes with the title Local Service Specification Measurement.
These are, Stan's touched on them as well.
The speakers discuss the points.
Measurements I don't intend to dwell too much on, because you may ask me an awkward question. So
I think for that's taken out of our service specification. Each service will have its own specification, but this street triage approach is in addition to the national criminal justice Liaison diversion, and what's being examined locally in our approach are these areas, and this is what we're trying to measure. So, in the simplest terms, activity, diversions, the conversion. What happens when somebody is taken to a place of safety? Are they actually detained under Section 2 or 3 of the Mental Health Act, or not? How many people end up in the A&E departments? Because we'll come on to that in a minute. The use of certain places of safety. Why is St Anne's used? Why is Royal Bournemouth used? Those that end up in custody. What I would say about the custody presentation is that if somebody is brought to custody with our practitioners there and with the relationships we have with police, if that person doesn't need to be in custody, they're still under Section 136, they can be conveyed to St Anne's Hospital and have their assessment taking place there. So that really promotes, again, effective healthcare. Some of the stuff we talked about, diagnosis, looking at prevalence, what we're actually doing, where is it taking place, are they currently known, previously known, and some of the bits we mentioned about demographics.
So can I just ask, just going back, you said that you could buy in from all the partners. What about the access to social care out of those? Because obviously we hear about the various cuts in funding going on within the local authorities and Dorset. Bit of a loaded question. Have you got that direct access out of those?
Yes.
Or is that...
It's what we have the access. It's what's done with the request after that can only be explained by local authority.
Yeah.
But we would like to think that by our service being available to assess presentation, recognise vulnerability, and make a proportionate referral, that we would expect the local authorities to respond to that appropriately. We're actually helping them.
Do you get the statistics on that as well? So you look at the journey from triage all the way through to accessing other services in a timely manner.
We will have access to information on referral rates. There's a bit of work that needs to be done, and it's very, very difficult to try and chart the outcomes on health referral, local authority referral, but it gets you into the sort of public health area, and it's something that has to be done to provide illustration. But how it's done, back into the system. It's part of our, when I say day service, it's part of what we do in the LD component, where we're expected to measure promotion, health and social care outcomes. Do you have to go? Yeah,
sorry,
yeah.
we've got a lesson.
Okay.
Sorry.
We're not being rude.
It's okay.
But there's a load of us that are probably
Yeah.
going to be doing that.
Thank you. Oh, 2 slides, he said, jokingly. Okay, we'll whiz through them, honestly. There you go.
Slide changes with the title Potential Benefits. The points are discussed by the speaker.
These are important, I think. Just look at it. In terms of...
So, we've got to talk about costs now, haven't we? I mean, that's the end of it. So these have come from West Midlands. Basically, it's £3,000 for every 1360 detention. So a couple of weekends ago, we had 6 1360 detentions being considered. The street triage mitigated that, so you can work out the math around that, can't you? And then every time they go to A&E. And then the big thing down at the bottom is the saving in efficiency. These shortcuts that we've able to, develop around getting into information and organisation. So that's the big one.
That's the cash and timings, but fundamentally it's the health and social care function. That's the big
Slide changes with the title Future Landscape.
And then these are things we're looking at going forward. That's why we're here. Top one.
Point reads, there is an acute requirement to raise awareness of mental health triage within the police, local authorities, volunteer organisations and the general population.
Building on what we've got. Second one.
Close integration.
Third one's a big challenge.
Sustainability.
Because where's the funding going to come from in the future? Ongoing for 4.
Active engagement in partnership working groups including multi-agency 136 groups, street triage steering groups, CCG, local authorities health project board.
5 is a big piece of work that I've got to do in my current role together with Stan about
continually developing joint training initiatives through the promotion of class ID tools and associated guidance documentation. Other points are not discussed.
How we get this joint training together with service users into the awareness at the front end, because this is where things impact.
The police are really skilled. Police are really skilled at doing their job. What we're trying to do is to get them to do their job even better, because practitioners cannot be beside police staff all the time, so it's equipping them with greater recognition through case identification tools and understanding mental health that bit better.
Just a quick question on the future landscape. Are there any plans for the information you gain from this pilot being put into training new police officers? Mental health awareness. That's an area.
This is right across the spectrum actually for police. If just be a little bit selfish for a moment, police officers. So it's from the moment they walk through the door to join a police service to when they leave. So there's the initial, then the ongoing development, and that's the kind of thing there. So it's not just aimed at one segment of the police; it's aimed right across.
I would have thought that your financial sustainability might have come from the Better Together programme as a result of the combination of various budgets coming together. Potentially that's where it could be funded, because when it's taking the work that you're doing, you're actually saving money. That's that wider picture.
That's for another time.
Slide changes to the title References and Further Information.
Those of you who are academically minded.
Points are discussed by the speakers.
Yes.
Don't worry.
It's just
There's not a slip test on this later on.
just some background. Like the Bradley report was revised.
Yeah.
So you want to read the original, you want to read the revised. Recently revised. Very, very informative. Talks about the journey of a person prior and through the whole criminal youth justice process. This is a big document as well, a national operating model, but again it tells you what our service does and associated reference articles. Again, we talked about the Concordat, useful link, and if you're ever at a loose end, you can look on YouTube at some discussion points from the CCGs, from Dorset Police, and from Dorset Healthcare in terms of the publicity behind the recent launch in June of this year.
If it makes it more palatable, I'm not on that, so please go and watch it. And there we go.
Slideshow's contact details: Stan Sadler 01202 705 523. Email stan.sadler@dhutf.nhs.uk. Simon Thorneycroft 01202 220 912. Email simon.thorneycroft@dorset.pnn.police.uk.
Some contact details. Yeah.
Thank you.
Okay. Thank you.
No.
we have overrun. I'm conscious of that, and I'm sorry that people needed to leave. So we're not really going to have time for questions as such. But what I'm sure both Simon and Stan will be around for those of you who can stay. There's information at the back too. Do we have any mental health nurses still here? A few of you.
Text on screen reads, if you would like to find out more about the dignity, diversity and equality work at the university, please contact Dr James Pelfman K, Equality and Diversity Advisor. Email diversity@bournemouth.ac.uk, www.bournemouth.ac.uk. Bournemouth University logo shown on screen.